This program is brought to you by Emory University.
This is ventricular tachycardia, an overview. It's meant mainly for board review purposes. So our outline today, we'll talk about generally an approach to wide complex tachycardia diagnosis. We'll move on to ischemic VT. We'll spend the most of our time here on ischemic VT. We'll touch on outflow VT, hypertrophic cardiomyopathy, and specifically its relationship to cardiac arrhythmias, VT in specific, and some a little bit slide about inherited arrhythmia syndromes. We'll focus there on ARVD. All right, so let's start with the approach to wide complex tachycardia. This can always be a source of trouble, I think, where we have this question of is this wide complex rhythm VT or SVT? In terms of board preparation and just I think also clinical practice, common sense is probably the first tool to be used, and I'm sure you'll hear this from others as well. When we consider how to differentiate between the two, the clinical scenario in which they occur becomes very important. So, in our patients who have known severe cardiomyopathy, who have known prior myocardial infarction, who have known prior VT, these wide complex tachycardias often end up being VT. I think from a test taking standpoint, the stem of the question often tells you what the rhythm will be. Um, the other thing I think that's important is that unstable VT and SVT, they have the same treatment. So, printing a 12 lead off is a great idea for later analysis, but ultimately the treatment for both of those is cardioversion. So I think that's also a useful thing to remember as you're, thinking about boards where, an unstable picture is painted and you're wondering between, amio or adenosine or this or the other. Well, if it's unstable, cardioversion is the right answer there. Uh, there are a couple criteria, quite a few actually out there, used to delineate which of the two you're looking at based upon the EKG itself. Two of the more common ones are the BRUGADA criteria and the Varecki criteria. The Varecki criteria uses one single lead AVR, which is useful because when we think about the vector of AVR, it kind of points right at the ventricle. You can tell a lot about which way the ventricle is activating based upon characteristics of AVR. Brugada criteria basically uses an analysis that's meant to ask the question, how fast is that tachycardia engaging the His-Purkinje system? Is it engaging the His-Purkinje first and then going on to the ventricle, or is it vice versa, which would be VT? And does it not engage the His-Purkinje system at all? Well, that's VT as well. So that's kind of the goal of both of these criteria. So Brugada, is a series of steps, and they're meant to be done in order. The first one is that there's an absence of an RS complex in all of the precordial leads. So what does that mean? It means that there is concordance of the QRS. It's either all R or all S throughout V1 through V6. And really, the only way you can make that happen is if your ventricular activation, the source of that rhythm, is coming from either the apex of the heart, in which case it'll all be QS, or the very base of the heart, in which case it'll all be R waves. There isn't really a way to generate that pattern using the His-Purkinje system or using a supraventricular tachycardia. Um, the longest R to S interval greater than 100 milliseconds in any precordial lead is our next criteria. This criteria basically is meant to say, is this thing engaging the His-Purkinje system or not? If it takes a long time, the RS is greater than 100, it indicates VT. AV dissociation is kind of the easy one, right? If there's the A's and the V's aren't connected, if there are more V's than A's, then that's VT. And then finally, we use the actual appearance. If we can't delineate between VT and SVT from the top three, we will ask, does the appearance of the QRS look like a right bundle or a left bundle? For the right bundle criteria, one way to do it is to just look at it and say, does that look like all the other right bundles I've seen? But in order to put that into words, will a monophasic R in V1, a big S wave with a little R wave in V6 would be unusual for right bundle. Typically, we see a small slurred S wave in V6 for a normal right bundle. So that's kind of the opposite. And if the R is larger than the R prime in V1, that's unusual as well. And that's a possible, that would indicate that you're looking at VT. For the left bundle criteria, we use slurred or notching and the S wave in V1. If the vector is entirely negative in V6, so a Q or QS, that's very unusual. Typically, we think we see rabbit ears in V6, basically all R wave in V6 for a left bundle. Or if the initial R wave is greater than 40 milliseconds in any lead, that's another way of telling. So the first thing to do in those, to use those criteria is to decide, hey, is this a right bundle looking thing or a left bundle looking VT? And you just basically look at V1 to delineate that. Is in V1, is it upright or is it negative? And that's how you use, that's all you are looking at to say that looks like a right bundle or a left bundle, and then you apply the relevant morphology criteria. Once you've done that, you go on to treatment. All right, so let's talk about ischemic VT. So ischemic VT is, first of all, the definition of sustained VT, 30 seconds or symptomatic requiring treatment in less than 30 seconds. So you don't have to wait for a patient to, elapse 30 seconds before you do something. If they're not doing well, you treat it and you consider that symptomatic sustained VT. In the setting of coronary disease, some of the earlier clinical trials of, using lytics for treatment of ST elevation MI, so they basically recorded roughly a 3% incidence of either VT or VT and VF. And those were really on the higher end. And the reason for that is that those typically were, in that era, the time to reperfusion was longer. And so the longer the reperfusion took, the longer the ischemic injury, lasted, and you'd have larger infarcts. And the size of the infarct and the delay in treatment are very strong predictors that you're going to end up with VT or VFib. The mechanism behind ischemic VT, really any VT, but it's basically reentry using diseased myocardium. In the case of ischemic VT, it's scarring is related to necrotic or hibernating tissue that's not perfused adequately. The things that happen within ischemic myocardium are that conduction slows. You have conduction moving in a nonlinear or anisotropic manner. So it's kind of not moving through the ventricle in an organized manner. It's kind of meandering through scar tissue. At a cell-to-cell level, cells become decoupled and there's fibrosis between the cells. So this makes it such that a conduction path cannot move directly from one cell to its neighbor. In some cases, it has to go all the way around a little focal area of block or of fibrosis to get there. So in these cases, conduction gets slow. Here's a picture of a case we did here at Emory, and this is a patient who had a left ventricular assist device. What we do when we map a left ventricular cavity, this is an LV, sort of looking at it straight on. We register the voltage at every point we can all around the ventricle. And so I've labeled here for you the LV, the cannulation of the LVAD. So you see a little cutout, a hole there. And then the LV outflow, just to orient you, is up in the top left near the yellow dot. The purple tissue here would be healthy tissue, would be normal. The not healthy, the ischemic tissue in this case, is all the stuff in the middle, all the red and gray. And these areas of tissue that are abnormal like this are a nidus for ventricular tachyarrhythmia and VT. So in this same case, this is a representation of that slow conduction. What you can see is at the bottom left of the colored picture there, you'll see that there's a catheter, sort of a shadow of a catheter, and it's pushed down into the septal distal region of the heart behind the LV cannula. And the picture on the right there is the electrical cording of those splines. And what you see there is a QRS. You can orient yourself to the top 12 EKG leads, and just underneath that in the red, yellow, green and blue splines, you see a sharp signal just underneath the QRS. That's pretty normal. But what's not normal is the second component that you see there. And that component is electrical activation through that area that occurs after the QRS has ended. This would be the definition of very slow conduction. And indeed, in this patient, this area was the source of the recurrent ventricular tachycardia that the patient was having. So when we think about VT or ischemic VT, you can kind of think about the timing here to tell you about what the overall risk is. From the early infarct period, say the first 48 hours, the incidence is about 2 to 3%. And generally, these are patients who present with late treated or late presentation of their ST elevation MI or their acute coronary syndrome. They often end up in bad congestive heart failure. And in some cases, the VT or VF may be an epiphenomenon reflecting a dying heart and very abnormal autonomic tone. In some cases, it's related to scar, but more often we think that these massive MIs, it's related to an epiphenomenon. In the convalescent phase, maybe the next couple months as the heart's healing, your risk is maybe 1 to 2%. And it's driven by how long it took you to get revascularized, how complete your revascularization was, and what your EF is. In the chronic phase, after day 90, the risk is pretty low, but it's variable. And again, depends on essentially what your EF is. But it's most likely in that 1% or less range. So when we think about treating ischemic VT, the first thing we think of is defibrillators. And so here's a summary slide of different phases of MI and the trials that have studied using ICDs there. I think the important lesson here is that the green box, the blue circle, which is dynamite and iris, those are negative studies. So if you take people who have low EF and you put in a defibrillator early, less than 40 days or acutely, you will make it so that they're less likely to die of arrhythmia, ventricular arrhythmia, but you won't make it that they're less likely to die. And that's kind of the purpose of the device, is to improve overall mortality. And as a result, we like to wait into that late post-MI stage. And we define that as essentially 40 days if you didn't get any revascularization therapy, or 3 months if you did. Here are the general recommendations. So you have 90 days for revascularized MI, 40 days for medically treated MI. And the overall recommendations are EF less than 35% with heart failure symptoms. So, some dyspnea or NYHA 2 or more, or EF less than 30% with no symptoms. And we use the EF as a surrogate for the amount of myocardium that was affected by the MI. The other key one is that your life expectancy should be greater than 1 year. All right, so let's talk about medical therapy for VT here. So here's a quick question. Which therapy here is going to reduce your risk of sudden cardiac death after acute MI? And you have basically all the heavy hitters, right? All the things that we might think of using after MI, certainly metoprolol, valsartan, beta blocker A or B there, and eplerenone and amiodarone. Generally speaking, test taking is going to tell you that this is probably going to be in all of the above, and that is the answer here. Here are some of the studies. The beta blocker data is old, admittedly. Miami and BHAT are very, at this point, they're fairly old studies, and they're studies that enroll patients who had MIs not treated with contemporary therapy. Nonetheless, beta blockers do seem to be extremely important, particularly in the short term, in preventing sudden cardiac death. I put commit on there, and some of you guys may remember that commit CCS was not a positive trial in terms of using IV metoprolol up front. And the rationale there, what we think happened there, is if you take people with large infarcts and as a rule, without any clinical acumen, give every single one of them high doses of beta blockers immediately, you are going to make some of those folks have cardiogenic shock with the larger MIs. And that was what happened in commit. Amiodarone was studied in SCUD-HEFT. You remember SCUD-HEFT, the medical arm was negative, but amiodarone did reduce your risk of sudden heart death from arrhythmia. It just didn't improve overall mortality. That question was actually on my general cardiology boards, like, 10 years ago, is that they wanted you to know that amiodarone worked for arrhythmia, but wasn't a mortality reducing agent for MI. Plarinone studied in ethicists, and I think maybe one other by now. There was a reduction in ventricular tachyarrhythmia risk. And then the ACE inhibitor studies are primarily low EF, but they do reduce your risk of ventricular arrhythmia there. So what happens if you have VT and VF despite your first line therapies, despite beta blocker or amio? Well, first of all, think about heart failure, think about mechanical issues. And the heart failure is really the big one. If the patient is completely decompensated with a heart failure, the first line therapy is to identify, treat, and optimize the heart failure syndrome. So that goes back to thinking about VT in the first day or two after an MI as an epiphenomenon event. Mechanical issues are, we spend a lot of time talking about them, and actually saw a handful come through during the height of the COVID pandemic. But VT may be a harbinger, or VF may be a harbinger of, myocardial rupture after a massive MI. And so thinking about those things early, it becomes paramount, because the mortality is extremely high with every, 10 minutes that passes without recognition, or 5 minutes even. But then we are left with antiarrhythmic drugs. So the antiarrhythmic drugs, basically, there are two big studies that kind of guide what we shouldn't use. We avoid class 1 agents, and we're cautious with class 3 agents. The CAST study was basically a study looking at class 1C antiarrhythmics, inconide, flecainide, maricezine, and imipramine between CAST 1 and CAST 2. An example of some of the mortality is shown in the top graph there, the top Kaplan-Meier curve. And what we basically saw is that these class 1 drugs worsened survival. They were not used for VT in that study, rather for PVC suppression, but nonetheless, the risk is notable. And so in folks who have structural heart disease from MI, we don't use class 1Cs. It is important to know that class 1Cs are a negative inotropic agent. So that, as you're thinking about where to use them in terms of decompensated heart failure at AFib, class 1Cs may worsen a bad heart failure patient's course. The Sotalol trial is a SWORD study, and notably, the SWORD trial studied only the D enantiomer of Sotalol, which is a class 3 antiarrhythmic. The D enantiomer makes Sotalol essentially a pure sodium channel blocker, a pure potassium channel blocker. The drug that's on the market is actually not the D enantiomer. It's a racemic mixture of D and L. And so the L is more like a beta blocker. So if you give someone the pure antiarrhythmic, it did worsen heart failure outcomes. And so there's a caution about Sotalol in folks with low EF. I'm sure many of you who've been in practice longer, you see that Sotalol in some bad heart failure patients will worsen their course. But for the most part, stable heart failure patients, just reduced EF alone is probably not an absolute contraindication. But it is important to make sure that they are maintained on both the beta blocker and Sotalol, if possible, or to use, the initiation of Sotalol with some caution there, with close follow-up. The advanced therapies that we talk about essentially are amiodarone and mexiletine. These are effective on reducing overall arrhythmia burden, but they don't affect your total mortality. Amiodarone is sort of an antiarrhythmic that affects many different channels. Mexiletine is a class 1B. It's essentially oral lidocaine. It shortens your QT. So we normally will start with amio and add mex if amio is not working. Catheter ablation is extremely important and plays a big role in VT treatment. It's affecting at reducing your overall arrhythmia. It is not a mortality procedure, but it will reduce overall numbers of ICD shocks, numbers of VT episodes, et cetera. We do have to think about procedural morbidity when you take some of these fairly sick patients. Thinking about who will do well with a 2 or 3 hour procedure is important. And it's also a procedure that if you wait too long, bad things happen. If you let the heart continue to deteriorate under the strain of a high VT or VF burden, the ablation is not going to go nearly as well. Having said that, most of the clinical trials of catheter ablation do suggest that it is better than long-term amio in terms of efficacy of reducing overall ventricular burden. There have been a lot of improvements in mapping and ablation. I could do a whole talk just on that. It's very exciting, the treatment of VT, in our ability to use mapping techniques to guide identification of critical parts of VTs, even what we used to think were just completely unmappable VTs. I'll show you an example of that later. So let's talk a little bit here about outflow VT. So outflow VT essentially is generally, we consider this to be like a idiopathic VT that occurs in structurally normal hearts. We normally see this in younger patients. Most of these come from the right ventricular outflow tract. And there is a female predominance when we think about population-based studies of this process. When we think about how to treat outflow VT, one big point that we consider is how many PVCs are too many. All right, so certainly for those who have palpitations, who have syncope, who have symptoms, we treat to get rid of the symptoms. Some folks are noted to have, say, bigeminy in the complete absence of symptoms, and there the treatment's a little bit more challenging. A general rule of thumb is that around 20 to 30% daily burden of PVCs, whether symptomatic or not, is going to be a red flag that you might begin to see PVC-induced cardiomyopathy. Luckily, PVC-induced cardiomyopathy is generally reversible as long as you suppress the PVCs adequately, whether that be through medicines or ablation. But that's one situation where you might be inclined to treat even in the absence of symptoms. It's interesting. We do seem to notice two sort of distinct syndromes with outflow VT. You have folks who have sort of repetitive monomorphic or single PVCs, and you have folks who have sustained VT runs. The folks who have the single PVCs that look the same just over and over again, they tend to have higher burdens. And the sustained VT ones tend to have lower burden but higher symptoms. The management here of outflow VT is essentially beta blocker, calcium channel blocker, and then you can use any of the antiarrhythmic meds, 1As, 1Cs, 3s. So that's sotalol, amio, flecainide. I typically start with a beta blocker and use verapamil as a second line agent before contemplating flecainide. It is important that we not miss arrhythmogenic right ventricular dysplasia. Some outflow VTs, especially those that don't look exactly like an outflow VT, maybe it's not dominant R in all of the inferior leads, so the vector doesn't really point toward the outflow per se. That may be actually the first sign of ARVD. So, looking or thinking about how the resting echo, EKG looks and how the resting echo looks becomes important. I do not order an MRI on every single one of my outflow PVC patients. There are those who do. I think it's overkill. I order an echo on most of them. I think for younger patients and those with a reduced EF secondary to these outflow PVCs, I think ablation is probably your best therapy, quite frankly. So here's an example of a slide here. You see that to the left of the rhythm strip, you have lots of PVCs occurring, and then you see a little marker there that says ablation on, ABL on at the very top. Then you have a nice run of PVCs, and then it's all gone. This PVC actually was mapped to the distal coronary sinus, so the left ventricular outflow on the epicardial aspect. So these outflow PVCs don't always just occur in the RV. They can occur in the LV. They could occur in the structures around the LV or RV outflow as well. All right, so that was outflow VT. Here's hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, you'll obviously hear quite a lot from others who are more versed in hypertrophic cardiomyopathy than me, but from a VT standpoint, it's important to know that the sudden cardiac death risk is quite variable. We think that roughly 10 to 20% of the overall hypertrophic cardiomyopathy cohort is considered at risk for VT and or higher risk for VT and VF. So what do I mean by that? It means that of all the people who have hypertrophic cardiomyopathy, maybe 10 or 20% would warrant primary prevention defibrillators. we help figure out who's who based upon certain risk factors. So, and the risk factors are listed there. If they have a history of VT or cardiac arrest, well, that's kind of easy. If they have a history of syncope and we don't know what that syncope is from, or it sounds arrhythmic, that's point number one. A relative with sudden cardiac death or aborted VT that was secondary to hypertrophic cardiomyopathy, that's point number two. Non-sustained VT on a 24-hour Holter. Typically, we're looking for more than like a single PVC or a couplet. You're looking for a burden. Abnormal blood pressure response on a treadmill. So a failure to augment your blood pressure is a normal, or augmenting your blood pressure is a normal response. Failure to augment is an abnormal response. And if the LV septal thickness or any thickness greater than 3 centimeters or 30 millimeters, if you have one or more of any of these factors, we think it is a good idea for you to get a primary prevention defibrillator. It bears mentioning that in folks with apical aneurysm and hypertrophic cardiomyopathy, this defines a very high risk cohort. So it's not that common that people have apical aneurysm and hypertrophic cardiomyopathy, but among that cohort, that particular phenotype has the highest rates of ventricular tachycardia and sudden cardiac death. It's around 10% per year at a minimum. If you have a patient with sort of burnt out hypertrophic cardiomyopathy, the F is low, the LV is dilated, those folks also have fairly high rates of VT and VF, about 10% per year. So those are two, sort of clinical scenarios that definitely you want to put in the back of your head as the highest risk for hypertrophic cardiomyopathy. So apical aneurysm and secondary cardiomyopathy. All right, so we're moving right through here. So inherited arrhythmia syndromes is next, and you can see here it's a pretty long list. And in the EP world, this list makes up like 20% of the board exam in terms of FACS or arrhythmia identification treatment. For general cardiology boards, it's still very important. It's not 20%, but it is important. And I'm not going to go into all of these inherited arrhythmia syndromes today, but it is important to know all of them as we set out in practice here. Long QT syndrome comes in quite a few varieties. The first three are the most common and the ones to remember there, I think. Arrhythmogenic right ventricular dysplasia, we'll show a case series on that in just a moment. And I'll talk a little bit more about that with that case presentation. BRUGADA syndrome, also very important. Sometimes you'll see this in unexpected places. Dr. Cutchins and I managed a patient a few years back who was actually started on flecainide for PVCs after she had failed beta blockers and calcium channel blockers. She was highly symptomatic, and when she returned for sort of a 1 week post EKG check after initiation of the flecainide, was noted to have a fairly impressive BRUGADA pattern. And so that was how it was unmasked. That challenge of a sodium channel blocker unmasked for BRUGADA. So it shows up in interesting places, not just as a pure arrhythmia. CPVT is a interesting autosomal dominant disease that manifests specifically with levels of high stress or a high stress situation. And beta blockers are fairly effective there, as is sympathectomy, but an interesting scenario that's useful to know. Short QT and early repolarization share a lot of underlying genetic and channel-based properties. These are a little bit more challenging. Short QT is pretty rare. Early repol, we see actually, a fair amount in young patients on the EKG, but not all early repol is the same. And I think early repol in the inferior leads seems to be a little bit different than early repol in the lateral precordial leads. And basically the degree to which you see that early repol it can be a clue that they might have one of these rare conditions. Idiopathic VF is kind of the trash bag that we put all the rest of them in. These tend to be normal EF females, and they have repetitive bursts of VF that you'll see on telly. This often is treated well with beta blockers, but sometimes requires either sympathectomy or Purkinje ablation, essentially targeting the Purkinje channel, or excuse me, Purkinje fibers in the septum of the left ventricle, it can be a very difficult disease as well to fully get control of, but thankfully quite rare. I think I've seen only a couple cases in the last 5 years. All right, so let's talk a little bit here about ARVD as we wrap up. So this is a common cause of sudden cardiac death in the young. The importance about ARVD is that epicardial VT substrate is very common. Essentially, what we see with ARVD is fibrofatty replacement of the right ventricle, and at a microscopic level, you'll see fibroblast formation and thinning of the myocardium. So there's less muscle and more connective tissue than there ought to be. What this leads to is pockets of focal right ventricular dysfunction. So that might show up as aneurysms or scalloping on imaging, like an MRI. And we see that the RV wall becomes very, very thin in some spots. It can present as either a heart failure syndrome or as a arrhythmia syndrome or as both. I think usually when it first presents, you see one or the other. To see both usually implies a later substrate or a later diagnosis. The medical therapies are beta blocker or sotalol. Sotalol does seem to be pretty effective for ARVD, as is beta blocker. And ICDs are used for secondary prevention in this cohort. We do have some primary prevention recommendations for ARVD, but they are it's pretty conservative. The ablation targets for ARVD are pretty interesting. The ARVD does not tend to be a diffuse process in terms of arrhythmia localization. It usually will localize to the RV infundibulum. So that's kind of like the outflow tract. The infraposterior tricuspid valve, specifically underneath or subvalvular space, and the RV apex. And interestingly, some people no longer think the RV apex is really truly a part of ARVD. The Dr. Farid, Tala Farid, one of our fellows, was doing some reading and shared a few articles in that regard with me. But typically we consider a triangle of dysplasia to be these three things. And I put plus minus on the RV apex based on that recent data from Tala. So here's a patient who presented is playing softball, felt his heart racing. It's like I think he's 29, otherwise very healthy, 32, otherwise very healthy, and came in with this VT. So let's just run through real quick and say, okay, first of all, this guy's 29, as far as we know, structurally normal heart, wasn't using drugs. He was playing softball, came in, felt palpitations. He was awake and alert with this arrhythmia and said, hey, something's going on. And in the emergency room, he was given amiodarone and then shocked out of this to normal rhythm. So if we look at this arrhythmia, the EKG, the way it's lined up here, you can see the markers on the left, 1, 2, 3, AVR, AVL, AVF, and then the precordials. So if we apply BRUGADA here, the first criteria is an absence of an RS complex through the precordial leads. And so let's see if that one checks or not. As we move through V1 through V6, we see that it's a QS in every single one of the leads. So this one right there tells you that this is VT, not SVT. When we look further about where this might be coming from, if I look at the inferior leads, it's 2, 3, and AVF down here are mainly negative. All right, so this is not coming from the base of the heart or up high. It's not coming from the outflow tract. Rather, it's coming from maybe the diaphragmatic portion of the heart. It's coming from down low. We can look at V1, which is a QS. It looks more like a left bundle than a right bundle. And that tells us that it's more likely to be either the septum or the right ventricular aspect of the heart. So now we're kind of localizing RV low down. One interesting pattern is that when you have completely negative things, QRS morphology in lead 2 and lead 3, especially with this little the notching in lead 3, this usually kind of speaks to an epicardial process. So we looked at this 12 lead EKG. This one I got from the lab, but this is the same as his clinical ET. And when we were talking to him and reviewing things, we immediately started to think this might be ARVD. So we need to get some advanced imaging before we do anything else. And sure enough, this patient did have ARVD. So what we did after we, talked to him about his diagnosis is we brought him to the EP lab and we mapped him. This map is meant to just highlight very late potentials in the epicardial space. And what you see is a PA view on the left and an AP view on the right. And this is sort of the infundibulum heading toward the pulmonary artery. So that's one of our areas. This is our subtricuspid valve infraposteriorly. And we did not see much at the apex, interestingly, much abnormality there. But we saw that, we saw the abnormal late potentials where we expected to see them. And what we did is we positioned a catheter right along the subtricuspid valve space. This was in the epicardial space. And then we induced VT. His VT cycle length, the speed of it was pretty quick. Clinically, it was about 250 beats per minute. In the lab, it was a little slower. I think on here it says it was 350, but I actually think it was a little faster than that for most of it. But we allowed him to be in VT for just maybe 30 seconds or so. But by positioning the catheter where we saw on the map the late potentials early, right away we could see kind of the secret sauce for his VT. What you see is that in VT, the QRS represents the uninteresting part of the VT in terms of how to ablate it. What you're looking for is the slow conduction that's meandering through the ventricle that's hidden. And that actually occurs in the diastolic period of VT. So if we look at this VT, you have a QRS and then a little diastolic corridor between. And as you let your eyes go down to the splines, the green splines below, this is our mapping catheter that's positioned right where the colors are on the map, which was that subtricuspid valve space. You can actually see how the VT, how it works its way through. It works its way from low to high. And so that's kind of going like this. The VT circuit is meandering its way through here and then coming back out again, and coming around and meandering through here and coming out again. When it comes out, that's when it actually makes the QRS. And to ablate this, to fix this forever, you treat this area where these signals are. So we, utilizing some of that mapping, we can really accurately identify where that VT is coming from. So we ablated that, and then I think he's going to do really, really well. He did well with this procedure and has done very well so far. So let's just wrap up with a few important points to remember here. So the first one that I can't state enough, beta blocker is your best therapy for VT and non-sustained VT. So whenever possible, the first thing you want to do is try to give the patient a beta blocker, whether it be small IV injections of metoprolol, esmolol drip. If you're on a bunch of pressors already and you're having a bunch of VT and your blood pressure is reasonable on pressors, in my mind, it would be better to just add a little bit of beta blocker and take the VT out of it before you start to wean all of your drugs. Now, that doesn't mean you have to give large doses of Coreg, but if you want to give very small, 1 milligram IV doses of propranolol or a small amount of esmolol, I think that clearly is the best way to tackle VT, and it works a lot of the time. That's why it's our first line agent. It's just one that we often forget. Amio, sotalol, and MEX are the antiarrhythmics of choice in that order. Sotalol with caution if you have tenuous heart failure. A quick word on sotalol loading. I do not normally load my patients in-house with sotalol. This comes up more with AFib than with VT because they're usually in-house anyway with VT, but the people who are most likely to have pathologic QT prolongation are folks with low EF, elderly, females, low body weight, bad kidneys. So if you have a patient with a bunch of those risk factors, those are ones to admit and watch. The ICD indications and timing, we touched on that, but the number one thing is ICDs early do work at preventing VT and VF death, but don't affect overall mortality. And so we wait. Outflow VT can cause cardiomyopathy, and so ablation is usually curative in those situations, and we should be going there early to get rid of the cardiomyopathy, not late. Apical aneurysm and HOCM is your worst of the HOCM phenotypes for arrhythmia. Knowing how to risk stratify someone with HOCM to determine if they need a referral for a defibrillator is important. ARVD ablation is pretty effective, and it's pretty effective if it includes epicardial ablation. So now that we've learned that, I think success rates are much higher with ARVD. Finally, the inherited arrhythmia syndromes, that's easy fodder for exams in terms of what channel genetic, linkage, whether it be recessive, dominant, X-linked, excessive. Associated exam findings for some of the syndromes that also have manifest phenotypes becomes important. So I'll stop there. I apologize for the technical difficulties earlier, and if anyone has questions, I'll listen intently.
Hey, I have a question for you. For patients who have HOCM and recurrent ICD shocks, given that they're younger and maybe you're thinking about the complications with amiodarone, is there a second best strategy for these patients, assuming that they're already on beta blockers, on high doses of beta blockers? Would you put them on amiodarone, or what are some of the things that you're thinking about for these cases?
I think ablation is what comes next after beta blocker, and in some cases, D-isopyramide can be useful as an antiarrhythmic, which should be pretty safe and may even relieve some outflow obstruction, but has high levels of anticholinergic effect. But I think ablation is where we often think of next. The challenge with HOCM ablation has to do with getting a good durable lesion. As we start to use more bipolar ablation, ethanol alcohol ablations, not in the arteries, but in the veins to target VT, I think we can do better at trying to help some of those folks. Unfortunately, some of these people end up quite refractory, and in those cases, ambio is the right step, followed by transplant evaluation.
I also have like a more technical question, I guess. If somebody has a heart rate of in their 40s and the 50s at baseline, how comfortable are we giving beta blockers, or are we going to go to another antiarrhythmic agent right away?
Yeah, I think that it's always worth trying a low dose beta blocker, but in those cases, if you have a class 1 indication for beta blocker therapy, but cannot because of sinus node dysfunction or AV block, that gives you a strong indication to use a device to support heart rate. So if I have a single chamber defibrillator in someone with sinus rhythm and cardiomyopathy who develops a heart rate of 40 and can no longer tolerate the beta blocker, in my mind, the easiest fix there is to add an atrial lead, use that to support the heart rate, and then give the appropriate medicine. The morbidity of adding an atrial lead is far, far lower, and the difficulty, quite frankly, is far lower than than going right to VT ablation. So that might be an easier first line step.
I have a question about combined use the beta blocker with sotalol. So what's the percentage with people with probably develop like a severe AV block or like a severe bradycardia?
It's actually not as high as you might think, and you do have to be cautious. Now, so I should say that I try to do both, and the reason is that sotalol is a weak beta blocker, and so if you have a cardiomyopathy patient, the beta blocker is kind of the cornerstone of their heart failure therapy in terms of morbidity and mortality reduction. So to eliminate that drug, to add sotalol should not be done lightly. I think that it often doesn't need to be done, so I guess what I should say is I wouldn't do it just as a blank action, like every time, oh, you just need one or the other. If you have someone whose pulse is, on no medical therapy, 55, and you're adding sotalol, that's probably all you need. You're not going to get away with more. But it's not as much as you think, especially the AV block. I think you're more likely to see sinus node dysfunction than AV block with sotalol. And again, if you need both, the pacer is a fairly easy fix to get you there.
The preceding program is copyrighted by Emory University.